afternoon. My name is Katherine Lamond. I am an assistant professor of surgery based here at Sibley Memorial Hospital in DC.
Hi, everyone. My name is Brett Parker, minimally invasive surgeon at Johns Hopkins, also based out of Sibley Memorial here in DC.
And I'm Alisa Coker, assistant professor of surgery, and I'm at the main campus for Johns Hopkins in Baltimore. So we appreciate everyone for joining us today. We're hoping to provide some information on GERD and Barretts and how those are related and when it might be appropriate to refer a patient for a surgical evaluation. So Brett, I want to start with you. Can you kind of educate us a little bit on what are the risk factors for Barretts?
Yeah, absolutely. So there's several documented risk factors for Barrett's. It occurs primarily in the setting of long-standing gastroesophageal reflux disease and chronic injury to the esophagus. So, having a documented history more than 5 years is a risk factor. It also is found more commonly in men over women and patients over 50 years old. Smoking has been noted to be a risk factor as well. Hiatal hernias, and erosive esophagitis as well.
So I feel like we all see a lot of patients that are referred to us for GERD and for Barrett's, but I know there's a lot of patients out there that aren't. So Kate, can you tell us when you would want to see these patients? When is an appropriate time for one of our referring providers to send them our way?
Sure. So there are a lot of different physicians that are usually involved in these patients, depending on the symptoms they're having. Sometimes a patient will present to a gastroenterologist or a primary care doctor with symptoms of reflux, debilitating heartburn, or even mid-epigastric pain. I think it's reasonable to be referred to a surgeon when those discomforts become debilitating. When patients have reflux disease that is breakthrough symptoms on PPI therapy, if they're on BID PPI therapy, or they have any concerning findings on any of their studies that they may have received, such as an upper GI or CT scan.
I would agree with that. I think it's also a reasonable time to ask a patient if they would like to see a surgeon, because I think a lot of patients aren't even aware that there are surgical options for this, things that we can offer them that will help prevent progression of their Barrett's to high-grade dysplasia and eventually cancer. And so I think it's important for them to have that discussion early on, and I would encourage that. So let's talk about what those surgical options are. Brett, can you give us a rundown on what are the options that you offer your patients when they come to you with these problems?
Yeah, absolutely. And I agree with you. Getting patients in early spectrum disease that really opens up their options. Most of the time we see Barrett's esophagus and medically refractory GERD patients in the setting of a hiatal hernia. So most of these options would require a hiatal hernia repair as well. And then it's just a matter of tailoring that procedure to suit the patient's physiology and anatomy. So, we do quite a bit of objective testing preoperatively to determine who's a candidate for what surgery. But in general, there are several options. The fundoplication is tried and true. It's the most classic approach, where you wrap the stomach around the bottom of the esophagus to recreate that high pressure zone and reinforce the lower esophageal sphincter. And that can be tailored several ways, partial fundoplications, complete fundoplications in various configurations. We also offer the LINX device or magnetic sphincter augmentation, which is a complete barrier as well. It's a ring of magnetic beads that go around the lower esophagus to reinforce the lower esophageal sphincter as well. And that's typically in patients who have documented esophageal motility that's not ineffective or weakened. So we know they could tolerate that procedure. There's the transoral incisionless fundoplication, which is another option. Originated in the endoscopy suite as an alternative to surgery for patients who didn't have hiatal hernias and early spectrum disease. And we've actually brought that device into the operating room as well. and we're combining that with a hiatal hernia repair. So that's termed a CTIF, or combined transoral incisionless fundoplication. And we're one of the few centers in the country offering that as well. And then as all of us here do weight loss surgery, we also know how to recognize patients with morbid obesity and also comorbidities such as gastroesophageal reflux disease that may benefit from a Roux-en-Y gastric bypass, not only to treat their reflux, but also their comorbidities and obesity.
Really good point that gastric bypass is also an option for some of these patients. I think, for us, we all know we're part of the division of minimally invasive surgery. It says that on our coat. But I think it's important to stress that to our providers too. So Kate, can you talk about how these procedures are performed? Are we still doing them through big open incisions?
I think it's a really important point that we make to our patients is that we always attempt to do minimally invasive surgery for all of these techniques, whether it be the full fundoplication or the partial wraps. Certainly the transoral versions of these procedures can be done without any incisions at all. But in general, we will talk to the patients about what options will work best for them, also depending on what stage they're in and where they are in their surveillance. And in terms of the Roux-en-Y gastric bypass, I think it's really important that the referring providers, that you don't need to make these decisions. We will help with the workup along the way. Oftentimes it can feel really intimidating to say, well, I'm not sure if I have all the studies before my referrals, but that's okay. We can help organize manometry and pH studies and EGDs if the patients haven't had them yet.
Yeah, totally. And we're always happy to discuss what would be useful beforehand as well. I think it's also good to stress that amongst all of us, not just us, but we have other partners that aren't included here today, we're able to offer a lot of these different approaches. And I think that's important. I think for me, for example, the majority of my hiatal hernia repairs and fundoplications are done robotically. And I think for some of it's laparoscopic, but probably most importantly, it would be rare to have to do that as an open procedure. I also think we can't just dismiss the fact that, especially maybe in the past, that these operations have had a little bit of a bad rap. It's not uncommon that I've heard from patients that they said, gosh, I've been suffering with these symptoms forever, but my GI doctor or my primary care doctor said, don't go get that done because it's got all these horrible side effects. And so I think it's good to stress what we offer. Maybe that's different than what they've seen otherwise. And that's we're all fellowship trained, minimally invasive surgeons. That means we spend at least a year of our life learning to do these procedures, and we do a lot of it. I know for me, it's about half of my practice. And so I feel like we're able to offer a very high quality procedure. And that despite a lot of the bad rap that you hear out there, no pun intended, there are definitely high satisfaction rates with this procedure. There have been studies out there that looked at over, just 1,000 people, asking them, how do you feel about this? And there's over a 90% satisfaction rate. In addition to them just feeling better in terms of GERD symptoms, Brett, can you tell us, what do we know about people who have Barrett's and they get a fundoplication, in terms of progression to high-grade dysplasia, for example?
Yeah, sure. So I just wanted to agree with everyone. I agree that the surgical interventions thus far have had a bad reputation and have a thought that they are plagued with complications and lifestyle changes and poor outcomes, and getting the patients in early to talk about that is certainly an advantage. And I'm really happy that we're doing outreach like this to make sure that that reputation has changed. I think it's the surgeon's responsibility to do that. Now that we are offering minimally invasive approaches. In response to your question, I think that the reason we don't see a lot of these patients is because they are managed medically, either through their primary care physician or gastroenterologist. And, we know that surgery can do just as much, if not more, in managing their Barrett's esophagus and not only stopping progression, like you mentioned, but also inducing regression. A lot of the Barrett's patients need to be quantified as to whether they're metaplastic or dysplastic. And if they have dysplasia, whether they have low grade or high grade, and that'll really change the rates of progression to esophageal cancer, which is our main concern. But in general, patients that undergo anti-reflux surgery can induce regression of their Barrett's esophagus. And I think that's an important point to take home.
Yeah, really important. It's also true that a lot of patients come to us just for symptoms and they're on PPIs, right? So Kate, for those patients who really want to come off their PPI or their providers think that it might benefit them because of potential long-term risks of PPI, what do you quote them in terms of the ability to get them off that medication?
Well, in terms of making the bridge from medical therapy to surgical therapy, there are obviously a lot of factors involved, especially whether they have a component of a hiatal hernia or paraesophageal hernia. Because the paraesophageal hernias really do need to be evaluated for surgical fixation, and all of the symptoms can't be managed with medical therapy. And true, there can be long-term side effects from the medications long-term. I typically discuss with patients how debilitating it is to take a medication every day. And I also sometimes have them try to take the medication every other day to decrease their medical therapy. And then I talk them through different options in terms of surgical interventions.
True. In addition to having to take that medication daily, the patient should also be aware, one of the risks of not having surgery, if you will, is really that continued persistent need for surveillance of their Barretts, right? While that won't necessarily go away in the short term, it's even more important if they choose not to have any kind of anti-reflux procedure that they have to undergo those procedures regularly to surveil their Barretts.
Yeah, and in general, I like to have the discussion with patients that, if we perform anti-reflux surgery for their refractory GERD or their Barretts, there's a really good chance that we can get them off of their medication. For example, my standard protocol is to stop the medication the day of surgery, and then we follow them. And you can either follow them objectively or subjectively. And, I'm very upfront with my patients and I tell them that there is a small chance you go back on your medications at some point in the future. But in some situations, say 10 or 20 years off of medications is still considered a success, a surgical success. You've altered their anatomy, you've corrected their reflux for that period of time. And then, say it does break down or wear out over time and they go back on their medications, they still had a very long period of time without gastroesophageal reflux disease. And so, although it's not a 100% certainty that they go off of their medications for life, it's a very good chance they go off it for many, many years.
So, Brett, Kate had mentioned that there are quite a few studies that we often require as part of the workup leading to the operating room. I think there are some maybe referring physicians out there that are concerned that once they send a patient to us, that they're not going to have ownership over them anymore. So kind of talk to me about how you manage that relationship and the need for all those studies with that referring provider.
Yeah, absolutely. It's complex, and that's because we want to do the right procedure on the right patient. That requires a lot of objective testing. So in the situation where we have a diagnosis of Barrett's, but maybe incomplete foregut workup, there is a burden on the primary care provider or the gastroenterologist to coordinate that and arrange that prior to presenting that to that patient to the surgeon. Well, obviously within our center, we don't necessarily require that. We have no problem completing that workup ourselves and assisting in arranging that. And so, yeah, we may step in and assist with some of the objective testing prior to surgery. And that's really just to make sure we identify the patient's candidacy and tailor the procedure. But we certainly don't expect to take over fully. And the reason for that is because Barrett's esophagus is managed in a multidisciplinary way. It requires not only the surgeon, but also the gastroenterologist and primary care provider. much of the advanced stages of Barrett's, dysplastic Barrett's, long segment Barrett's, is managed with endotherapy first and foremost, prior to the surgeon even meeting the patient. And certainly after surgery requires ongoing surveillance, and making sure that patient isn't lost to follow-up, making sure that patient doesn't have progression of Barrett's to esophageal cancer, takes a village. And so the surgeon can't do it alone. And certainly we welcome and encourage ongoing long-term care to be provided by the primary physician and the gastroenterologist as well.
Agree. It's definitely a multidisciplinary approach. I'd say more often than not, most of my referrals for Barrett's now are sent to me pre kind of any ablation therapy, with the plan being, hey, let's control your reflux first. Let's give you some kind of anti-reflux procedure, and then we'll plan for an ablation afterwards.
Yeah, absolutely. And we also have the ability to recognize and identify patients who have advanced disease and may benefit from being triaged by a thoracic surgeon as well. In the rare case that they fail endotherapy or mucosal resection for discussion about esophagectomy. So it's a one-stop shop and a comprehensive center.
Agree. Well, I hope that this was very useful for anyone watching. I want to stress that we would love to answer any questions that anyone might have. If we can provide any clarification, we would love to be able to consult with your patients and educate them directly. So please reach out if we can be of assistance in that manner.
Thanks, Alisa.